So you're going to, when you're doing an NG tube, you need to gather your equipment. When you're doing the placement, you need your NG tube, you need a catheter, tip syringe, pen light, tongue blades, glass of water, pH paper, tape, and lubricant. And then a towel and a washcloth is always nice to help keep your patient cleaned up. So when you'll get your doctor's order, and then you'll go into the room and do what? Wash your hands. Identify your patient. Hi, Mrs. Garcia. I'm Sean. I'm your nurse today. Can you tell me your name and your date of birth? Okay, so your two patient identifiers. Okay. Then I'm going to explain the procedure to her. Hi, Mrs. Garcia. I'm Sean, and I'm here to put in the NG tube that the doctors had ordered for you. Did he tell you about that? No, he didn't. They never tell you. The patient. So the doctors ordered an NG tube to be placed in your nose, and it's going to go into your stomach, and it's to get rid of all the acid and secretions that you have in your stomach that is making you nauseous. He's going to probably want to keep that in there for a day or two. Okay, honey, do what you need to do. That was my granny, Connie Garcia. I named this mannequin after her, so she's nice to me. Okay, I'm going to raise the head up to a working level. I am going to also tell the patient about the procedure because we're going to have her help. So Mrs. Garcia, when I'm going to put in this tube, first of all, I'm going to raise your head up so you're sitting up a little bit higher. And then as I put this tube in your, after I put it in your nose, when it gets down to your throat, I'm going to ask you to tuck your chin to your chest, and then I'm going to ask you to drink some water, because that will help, your swallowing will help put the tube go into the right place. Okay. So, when I'm measuring the tube, I'm going to measure it from the tip of the nose to about the ear, and then down to the xiphoid process. Okay, did you guys see that on the side? Okay. Then you're going to mark with tape or a Sharpie where that would be, so you know how far to go. And coil this up. These have been used quite a bit, so they're not quite as hard, but when they're brand new, they're a little stiff. So if you kind of coil them and warm them around your finger, they'll go into the right shape that you need. Okay. You're going to lubricate the tip of your catheter, thank you, the tip of your NG tube, about 5 inches or so. Okay. A good reference is however long it takes to go from that nose to that ear. Okay, because that's your nasal pharyngeal area that's going to be the most fragile tissue. So lubricate it up really good. I'm going to have my stethoscope is back over there again. Behind you. My pH paper hand, okay, and I am ready. I'm going to put a towel down because oftentimes the patients might feel a little bit nauseous when you're putting this down. So an emesis basin nearby would be good as well. Okay, so, okay, Mrs. Garcia, I'm going to check and see which nares is patent. I'll ask the patient to breathe through each nares to see which one's more patent in case they have a deviated septum or something. I'm going to enter through the nares, head's kind of back so I can see, and then once I get to the back of that throat, I'm going to ask them to tip their head forward, and she should be holding her water, and I'm going to ask her to drink and swallow. And as she's drinking and swallowing, I'm going to be twisting the tube and going down. As you twist the tube, it helps lead the tube through the pharyngeal area into the back of the at the back of the throat. Okay. They might cough. If they're coughing and it sounds like it's in their lung, you'll pull back. They'll have a higher pitched cough, just similar to when you're coughing if something goes down the wrong pipe. If it's kind of like a cough gag like you do when something gets in the back of your throat, you know the difference, right? Okay. So these tubes don't come out very easily. They might slip a little bit, but they won't come out very easily. So I can just loosely hold it, okay, and just watch it. Make sure not to pull it back out. I will do about a 20 milliliter air bolus, putting my stethoscope over the epiglottic area. Hear a whoosh. You go really fast so you can hear the whoosh, not slow. Draw back some gastric content. Test that on my pH paper, and it should be less than 5. Okay. And then I can look in the back of the throat to make sure that it's not coiled, that it's going straight back. And I can get ready to tape it. Do a split piece of tape. Some hospitals do have those special adapters that will hold it. And then the split tape goes around the tube on one side and then in the other direction on the other side. And basically what that does is it takes the tube on either side and it's kind of holding it still like this, so it doesn't move and go back and forth.
That blue tube is just a stopper?
This is called a pigtail, and it's for venting, for when the tube goes to suction. Because this is an NG tube, a psyllium slump, that can be used for gastric decompression as well as feeding. Okay. I like to reinforce the dressing or the tape around the nose and go across so that it sticks. Then you're going to give a little slack, piece of tape, so this can be pinned onto their gown. So if this gets pulled, it doesn't pull the tube out. Okay, so cloth tape usually works best. Okay, then I'm going to clean up. How's that feeling, Mrs. Garcia? I know. And the words that we need to hear from you are, before I use this tube, I will check with X-ray for X-ray confirmation and placement. You have to hear that. I'm going to put the bed down, patient safety, give them their call light. Gloves, and then go order the X-ray. So after X-ray is confirmed, we would put this to suction. Now I'm going to tell you the truth, in practice, oftentimes when you're in the stomach and you're putting an NG tube in for decompression, you're getting a lot of stuff out fast. So we would fully decompress the stomach before we did the X-ray, while the X-ray is coming out, and then clamp it so that the patient doesn't vomit and they feel a little bit more comfortable. Okay. But before we hooked it up to continuous intermittent suction, we would make sure that we had that X-ray confirmation. But if you're getting out a liter of fluid, whether it's in the stomach or the lung, it still needs to come out. So we will decompress. Okay. So then the second part of your checkoff is you're going to come in and introduce yourself to your patient, because now the doctor's ordered bolus feeds to start. Okay.